Hi, I'm Mr. John Harrison, endoscopy lead and consultant surgeon at Harrogate NHS Foundation Trust. Today we're going to be talking about esophageal dilatation and the reasons for doing that and the reasons for not doing that. So first of all, the commonest cause of esophageal dilatation is peptic strictures due to gastroesophageal reflux disease, but there are other causes such as eosinophilic esophagitis. You get sometimes quite difficult to manage post-radiotherapy strictures and post-surgical strictures, and the ones that can be really difficult to manage are quite long and irregular caustic ingestion strictures. We tend not to dilate malignant strictures, although sometimes in a palliative setting that is appropriate, so it's a relative rather than an absolute contraindication, but we really try not to, particularly in the primary setting. We don't want to perforate a cancer and go from a potentially curable to a potentially disseminated situation. So part of the assessment is to make sure that we're not dealing with a stricture that is malignant or an achalasia that is actually a pseudoachalasia, where you tend to have a shorter history in an older patient than what we normally see with achalasia. Achalasia is obviously another cause for dilatation, and that's not infrequent. And then there's less frequent causes such as webs, as in Plummer-Vinson or Patterson-Brown-Kelly syndrome, and obstructing Schatzky rings, although they are less common. So going on to assessment of the patient, first of all, obviously you take a full history and you examine the patient, and then move on to doing an upper gastrointestinal endoscopy, which by intent will be an assessment to start with, not you don't go straight to dilatation. In the first instance, you want to assess what the stricture looks like, the level of probability that it's malignant, and you'll want to get biopsies. So you do that at the first sitting. Having done that and assessed it, you may well then want to go on and do a CT scan to assess the esophagus further above and below and at the site of the stricture. And sometimes in the case of a long caustic stricture, you may well want to get a bit more of a roadmap by doing the bearing study. And then once you've got all the information together, you'll see the patient again, discuss the diagnosis and the way forward if it's not a malignancy, and obviously if it is, then you'll go on to staging and management of the cancer as appropriate. But if you are then going to do a stricture dilatation, you will want to discuss with the patient the likely incidence of problems and complications. Principally, these are around perforation, hemorrhage, aspiration, and restenosis. Perforation said to occur in about 1.1% of cases in a recent BSG study. So going on to the procedure, first of all, obviously you need to consent the patient, and you'll need to discuss a bespoke level of risk with the patient. The most outstanding one being about perforation being around 1.1%, as discussed previously. And you will have also agreed with the patient whether they are going to be done under sedation or under a general anaesthetic, depending upon the stricture and patient's preferences and your own preferences, depending on the degree of difficulty of dilating the stricture. The types of dilators in use are in two groups. They tend to be bougies. So there's the old type of Maloney bougie that used to be a long rubber tube filled with mercury, but is now made with tungsten and can be used safely with short proximal strictures, with the self-dilating with the patient doing it. But for any other sort of stricture, these are not to be used any longer, not safe. Then there's the wire-guided Savary-Gillard type of stricture, where you progressively dilate a stricture, blind though, over a guide wire. So this tends to be used less frequently than through the scope balloon, such as this type of Boston Scientific through the scope balloon, which has 3 diameter settings depending upon the pressure exerted on the balloon during the dilatation. So you pass the balloon through the scope into the stricture, and you get to the halfway point, or what you judge to be the halfway point, which applies a steady radial pressure to the stricture in a safe way. So you get the balloon halfway into the stricture, or where you judge to be halfway. But what you'll find if the stricture is tight is that the balloon will be pulled into the esophagus beyond, if you've got it slightly beyond the halfway point, and if you're a little bit shy of the halfway point, it'll be pushed back. So you need to experiment with the positioning with some slow, gentle dilatation to start with, and then once you've found the halfway point, so it's neither being pulled in or pushed back, then you do the dilatation. And the way that you do that is you ask your nurse assistant to inflate to the first position and hold it. In the case of this balloon here is a 10 to 12 balloon, so starting at 10 millimeters. Then when you're happy, after 30 seconds or so, you take it up to 11 and then to 12 millimeters. And you may decide, if it's dilated remarkably easily with soft stricture, that you might take a further balloon at that time to go up to a further 3 millimeters. But mostly you will probably decide to bring the patient back after a couple of weeks to take that size up to the next level, because you don't want to do too much too soon and run the risk of perforating the stricture. And then if you're happy with your dilatation, you ask your nurse assistant to deflate the balloon, and then you pull it out, and then you assess what you've just done and see if there's anything to worry about in the stricture before coming out. And the patient then goes to recovery and to have a period of a couple of hours where they're observed. Obviously, if during that time there is any evidence of tachycardia, of pain, of subcutaneous surgical emphysema in the mediastinum, then you'll want to suspect that there is a perforation, and you need to arrange an urgent CT scan and admit the patient surgically for management, unless the view is that a covered stent will be the option, in which case you take the patient back into the endoscopy room and do that. Other complications include bleeding, although that is unusual, and an aspiration can also occur, but again, it is unusual. And obviously, it's always possible that restenosis may occur, and if that happens, then you would have to repeat the process, possibly in conjunction with some steroid injections of triamcinolone into the stricture to soften it up before doing a repeat dilatation. Going on to achalasia, that is a slightly different process. It's one of a number of options now in the management of achalasia, but it's still done in a proportion of patients, although it is less well controlled than POEM or laparoscopic helismyotomy, but obviously it has a place in a proportion of patients. So you do it under screening control, passing a guide wire through the cardia into the stomach, and then passing the 30 or 35 millimeter balloon over the guide wire, and then under screening control, inflating the balloon. You see the waist forming, and then popping open when the circular muscle stretches up, and then you deflate the balloon, and hopefully the patient will see some benefit from that. So that concludes the medical aspect of the esophageal dilatation procedure, and now Bernice Maffoli is going to go on to discuss the nursing aspects of the procedure. Yep.
Yes, so we have all these different types of balloons. These balloons are from sizes 6 mm to 8. There is another size which is 10 to 12. There is another one which is 12 to 15. There is another size which is 15 to 18. There is another one 18 to 20. So when you have got to bring them, you need to bring all these various sizes for the reason, because the endoscopist will decide which size they will want to use, depending on how the stricture will be like. It can be esophageal stricture, it can be colonic stricture. So the next stage is just to patch the syringe, and we always make sure that the gauge is facing upwards, because that is our softener. That's the better way. And while we are doing that, this gun needs to be, this should be on the neutral mode. The amount of water I've drawn up already in advance is 35 ml of water. You can either do it before, or some people can use this and draw it with the syringe on, but don't bother. That may actually be more confusing for you. Just stick to the method which I think is basic and simple. So I'm patching this now. We just patch this in through like that on the neutral position, okay? So we have got this to lock it in, so it's all locked up nicely. And this is actually facing up the gauge. So what we have to remember is we are going to connect this to our balloon. I have been asked to get the balloon. And then, like I said, the balloons are in different sizes. This balloon which I got is with size 10 to 12. This is the one I have opened already in advance. You need to make sure it has not expired. Good. At the end of this, there is the connecting end, which is that. Connect it there. Lift the guide wire in because it keeps the dilatation balloon rigid and easy for insertion. But it may be ideal to remove this end of that. It's not easy for you to see it, especially when you haven't used the dilatation balloons for so long. Be aware, you don't want to put that down the biopsy channel. Then when you are happy with this, the endoscopist will say, okay, I'm ready. What you need to remember, just have a look. When you look at the tip there, the guide wire is a bit at the back. So what I'm going to do is to advance it a little bit. And then I'll unlock. This is the locking and unlocking, as you can see. Now I'm able to advance it up to the end where it's just okay, so that the balloon is not going to be like wobbly. Yeah, so now lock it. Why do we have to lock? So that during the insertion, you don't have to worry about that. You just give it to the endoscopist, and then it's not going to be on in, just confusing everybody. And then that's fine. The endoscopist will now start. Unlock is on neutral mode. Then we are in the position to remove our syringe. Then we will deflate. This syringe is just single use, so remember we'll throw that, we can never use. The balloon is also to throw. It's just according to your guidelines on how we throw the balloon away. Remember again, we need to reuse the gun. So we need to clean, disinfect it with the wipes. Keep it safe for next time when we need to use, so that you don't have to worry that it's lost. Thank you.
Okay, so that concludes our brief video detailing the medical and nursing aspects of a safe esophageal dilatation. Thanks for watching.